Let me start by asking a question from you. If someone has a disease of stomach, no matter what disease is, what do you think that, what will be the symptom of that disease? Oh, very nice. Patient may have pain. Pain where? Pain in epigastrium. Yes. Patient can have a pain in epigastrium. What type of pain? Yes, burning pain and or it may be colicky pain. Okay. What's the difference between these two? What are the type of diseases in which we have a burning pain and what type of diseases in which we have got? Yeah, okay. If the sensitive mucosa is touched by low or high pH chemical, then we have a burning pain. And when we have a colicky pain? Yes, very nice. Any muscular organ, when that organ tries to contract very vigorously, and usually in order to undo the obstruction, then there is colicky pain. And there can be a persistent pain as well. And there can be a dull, for example, if there is a tumor which is expanding. So very nice. So please remember that if someone has got pain over here, then this might be something wrong with the stomach. What else? Very nice. Vomiting. Yeah. By the way, what is vomiting? What do you understand by vomiting? One way. Yes, expulsion of the contents of the stomach through reverse peristaltic movement. So anything which is blocking can cause vomiting. Anything which is irritating can cause vomiting. Okay, very nice. What type of vomiting it will be if it is causing an obstruction? Very nice, you understand that. See, vomiting is an activity which is a reflex activity and which is initiated in the stomach, right? However, the signals pass through a center in the brain, right? So that center can directly be stimulated as well. There are certain diseases which directly stimulate that center. For example, raised intracranial pressure. For example, certain drugs. For example, motion sickness. Now, they need not to pass through the stomach. They directly can do that, right? And the vomiting which is directly from there are usually not projectile. But these reverse peristaltic things are. So, very nice. What else can be the possibility if there is something wrong with the stomach? Okay. We use a term dyspepsia. Dyspepsia is a vague term. जिसे हम कहते हैं बदहजमी हो गई, खाना हजम नहीं होता. There are a lot of symptoms associated, bloating, full sense of fullness, all these things. So it is possible that when someone has a disease of stomach, this may be the symptoms, right? And this is a symptom of so many diseases, but stomach is one of them. Okay, what else, please? No, people from the back now, please. Okay, why there will be abdominal distension in stomach pathologies? No, I'm talking about stomach pathologies. We are discussing surgical disorders of stomach. If someone has a disease of stomach, then how patient will present? Okay, anyone? Anemia. Oh, very nice. Very nice. Anemia may be a presentation. Now, what relation anemia has with the stomach? One by. I mean, I can't understand when everyone is talking. One is because stomach is actually responsible for production of hemoglobin through what? Yeah, iron, it has got effect on iron metabolism through the intrinsic factor. Moreover, stomach has to do with the nutrition as well. When there is something wrong in the stomach, there is a possibility of malnutrition as well. So anemia may be a possibility. What else, please? Oh, very nice. Hematemesis. What do we understand by hematemesis? And what is hemoptysis? Blood in the sputum is called hemoptysis and blood in the vomiting is called hematemesis. Okay, why there will be hematemesis? One by one, please, so that I can understand. Oh, upper GIT bleed because of peptic ulcer, because of esophageal varices, they are, and tumor as well. Because tumor, beta settle in quickly. Settle in quickly. Request you to please come in time so that this trouble doesn't occur. Settle down. Time waste hota hai na. Okay. Anything else, please? Weight loss. Very nice. Especially whether it's a benign disease or a malignant disease, because food has to pass through it. When there is something wrong, there can be weight loss, and malignancy as such can also cause weight loss. Anything else? Okay. Palpable mass. Yes. Very nice. If there is block somewhere, stomach may distend, and there can be a distended stomach which can be palpable as a mass, or there may be actually a solid mass because of the tumor. It is possible. Anything else, please? Oh, that is dyspepsia, no? That is part of dyspepsia. Anything else? Patient will not say, I will have regurgitation. I am talking about the symptom. Now, this is very important. Then there can be melena. What is melena? Yeah. Whenever there is blood in the gastrointestinal tract, it is irritant and tries to go out. If it is in the upper part, it will tend to come out through the vomitus. If it is in the lower part, it tries to come out through the feces. Now, whenever bleeding is in an area which has got an acid, and hemoglobin has got a contact with acid, the hemoglobin changes into acid hematin, which is black in color. So, melena is not bleeding per rectum. Bleeding per rectum is technically called hematochezia. Melena means black stool. Patient doesn't say कि मुझे पखाने में खून आता है. What he says is कि मुझे काले रंग के पखाने आते हैं. So this is indicative of any pathology. Now why I am actually starting with this is that please remember, anyone, you are sitting in OPD or you watch it, you examine an admitted patient. If he has got any of these symptoms, there is a possibility of a stomach disease. Now in life, we should not be suspicious, but in clinical sciences, we should be very suspicious. Anything which is possible can happen. So please remember all these symptoms. Whenever a patient will come with any of these symptoms, stomach pathology should be in our mind. So is this clear? Apart from that, sometime, though very rarely, patient may present for the first time as symptoms of metastasis. For example, someone comes with ascites, it may be because of CS stomach. The tumor is not big enough to cause mechanical symptoms, but it is rare. Similarly, first time you palpate a lymph node over here, which is called Virchow's lymph node, and this may be because of CS stomach. Very rarely you can have a palpable liver, and it is because of metastasis. But these are the usual symptoms of stomach. Now, after discussing this, now we will just touch some of the theoretical points, because understanding of those theoretical points are very important to understand the diseases of stomach, right? Let me draw stomach for you. Anyone can tell me the embryology of the stomach? How did it develop? Okay, let me give you a hint. It was, the whole gastrointestinal tract was in the form of one tube. Okay, which is called enteroderm, enterodermal in origin, a tube, just one tube. Now, because of the physiological needs, some areas dilated and some areas they did not, right? Now, the whole tube had a mesentery. समझ में आई बात आपको? Let me draw it for you. That tube, it had a mesentery, which is called posterior mesentery. And through this mesentery, blood vessels, nerves, lymphatics, they pass. And similarly, there is an interior mesentery as well. The whole gastrointestinal tract had a posterior mesentery and an interior mesentery. Now, this is required because blood vessels are coming. Why this is required? This was required because in the intrauterine life, the blood was coming actually from the placenta through the interior mesentery. Otherwise, the blood would not have entered inside. And the derivatives of gastrointestinal tract are liver, gallbladder, pancreas. They are the derivatives of this. Now, blood had to go over there. So, there was a channel present interiorly. So, if you visualize my tummy, From here to here there is a tube. A tube has got a mesentery coming anteriorly and a mesentery coming posteriorly. Now the interior whole of the intestine actually did not require blood supply to be coming from the placenta. So this mesentery actually disappeared above the esophagus and disappeared below the duodenum and only stayed in the portion from lower end of the esophagus to the duodenum. So can you visualize it? Can you visualize it? This is the stomach and there is a mesentery here, and like a curtain it is just from lower end of the duodenum up to the from the duodenum up to the lower end of the esophagus. Now in this mesentery liver developed. This is why from the placenta when blood came, it used to come into the liver and then from liver through the portal vein and then inferior vena cava and back. So liver developed actually in between this. Now when liver developed there, it was very big. It was very big. There was no place. So intestine has to go out. You remember that? So that liver can settle. But when liver was present anteriorly, it could not settle in that space. It actually shifted to the right hypochondrium. And as a result, the whole of the intestine from the stomach up to the duodenum had to swing on this side. So this is why this portion of the stomach was actually facing anteriorly and this portion was actually facing posteriorly. But because of the liver drew it like this and stomach became like this. So this is why the original interior border became lesser curvature and the original posterior border became the greater curvature. And then the mesentery, which was again facing towards the interior abdominal wall, now is laterally facing. And here is the liver. And then it continued like this. This continuation is called ligamentum teres, which actually passes through the falciform ligament and attaches to the interior abdominal wall. And this portion is liver. Now this actually goes over here and becomes the Glisson's capsule. And from here again it goes like this, and this is called lesser omentum. Okay? And from here the greater omentum hangs down. Now this portion, as I've told you, was just up to here and just up to here. Did you understand it? Any big ambiguity in anyone's mind? I think it is clear. So this lesser omentum actually is a part of the interior mesentery. Now since it had to be sharply cut off from here, as a result there is a hole at the lower end of it. And this hole is actually going behind the stomach, obviously. ऐसे था ना सामने, यहाँ से कट गया. When it turned like this, there is actually a lower, this curtain has got a lower hanging border. So lesser omentum has got a lower hanging border. And that lower hanging border, if you put your finger in, this is called epiploic foramen. Right? And it goes behind the stomach, and the space behind the stomach is called lesser sac. It becomes lesser sac. Okay? And this is the place where three vital structures are actually passing. If you put your finger there and thumb above it, what you feel is portal vein, hepatic artery, and common bile duct. And this is anatomically very important point, because if there is massive bleeding during cholecystectomy or any biliary surgery, you just put your finger in and just press it and bleeding stops. And this procedure is called Pringles Maneuver. Pringle is the name of person. So when you'll go in a surgical ward, I wish it never happens, but if there is bleeding, you just put there and compress it, bleeding stops, right? So this is the anatomy of it. I hope you understand that. Fine. Okay. Now this portion is called what? Fundus. This is body. This is antrum. This is pylorus. And from here, duodenum starts. And there's a very important landmark here. All the veins, if you just see there on the stomach, they are on the longitudinal direction. But one vein is actually on this direction. This is called pre-pyloric vein of Mayo. And this is actually a demarcation between the pylorus part of the stomach and the duodenum. Right? Okay, now we take some of the other anatomical points about the stomach. The arterial supply. So please give me some rest to my vocal cords, and I'll ask someone with a good anatomy to please quickly beta. Oh, okay, fine. See, there are you go to YouTube and you can watch anyone, but still people pay a lot of money, buy tickets and watch people live, right? There is a difference between live watching and just videotaping it. So anyways, so anyone who can tell me anatomical points, the blood supply of stomach, because this is very important surgical point of view. Anyone has any idea? Okay, we can start from here. Okay, there is an artery which is a direct branch of aorta, which is called celiac artery. I hope you remember that whole intestine has got 3 major arteries. Yeah, celiac artery, superior mesenteric artery and inferior. And according to the anatomical distributions, they supply various parts of stomach. Now this portion of the upper GI is actually supplied by mainly celiac trunk. How many branches celiac trunk has? 3, okay. Splenic artery, yeah, okay. Left gastric artery and common hepatic artery. So actually we'll start by one word. From here perhaps there is a branch which is called left gastric artery, and it goes like this, left gastric artery. Then it has got, it runs along the gastric curvature. And then there is an artery called common hepatic artery. Now common hepatic artery here gives actually one branch which is called gastroduodenal artery. It's a very important artery, gastroduodenal artery. From here, let me draw it here for clarity, like this. It goes down and actually it goes behind the duodenum. And when it goes behind the duodenum, it divides into right gastroepipolic artery. And then itself continues as a superior pancreaticoduodenal. Sorry for these terminologies, but I hope you remember them already. So it has got a right gastroepipolic artery which runs along the greater curvature, and it has got a superior pancreaticoduodenal artery. Now this artery is the one which is going to make an anastomosis from inferior pancreaticoduodenal artery, which is the branch of superior mesenteric artery. Now, आजो बेटा आ जाओ, लेकिन टाइम पे नहीं, कोई बात नहीं, आजो बेटा आजो, get in quickly. Sir, अगले लेक्चर में कितने बजे आओगे? पूरे आओगे, शाबाश, thank you very much. I trust you. Yes, I trust you. How can I not trust, my children? You are my future. I have to trust my future, right? Okay. All right, okay. Now this artery is very important, especially that segment of it which is passing behind the duodenum. Can someone tell me the importance of it? Shabash. अच्छा ऐसा है, the ulcer, duodenal ulcer, which is commoner, amongst between stomach and duodenum. Duodenal ulcer, when perforates anteriorly, it causes peritonitis, obviously. But when ulcer is present posteriorly, this ulcer may erode the gastroduodenal artery. And this is a very high pressure vessel. It is almost directly coming from the aorta. So when posterior ulcer perforates, there is a massive bleeding and patient can succumb in minutes. If you don't do something, patient may die. So this is the importance of this artery, that it is involved in the perforation of the posterior part of the duodenum. Okay, now this is gastroepipolic artery. Now right gastric artery is a branch. After this there is right gastric artery, and this continues as hepatic artery and divides into two, the right hepatic artery and the left hepatic artery. And the right hepatic artery gives the cystic artery. समझ में आई बात? Right hepatic artery gives a cystic artery to the gallbladder, and then it continues to supply the right half of the liver, and left one goes to the left heart. Most of the times, although there are certain variations as well. And right gastric artery actually goes like this, and they make a loop with that of a left gastric artery. Left gastric artery is coming from the top, and right goes from here, and then they make an anastomosis, right? And here there is a splenic artery which is passing somewhere behind like this. It is actually destined to supply the spleen, but before that it gives a branch little higher up, perhaps here, and it gives a branch which is left gastroepiploic artery, which actually joins with the right gastroepiploic artery, and some of its branches directly go and supply to the stomach, which are called vasa breva or short gastric vessels. So in other words, stomach is all encircled, with vessels, left gastric artery, right gastric artery, right gastroepiploic artery, left gastric epiploic artery, then splenic artery has got vasa breva. Now this loop is very important. Splenic artery's loop, which is coming from here and supplying over here. Now why it is important? Because we will learn later that in many of surgeries of esophagus, what we do is that we use stomach as a tube. In case of tumors of esophagus, we actually remove the esophagus and replace it with a tube of the stomach. And when we have to mobilize the stomach, please remember that we sacrifice all left-sided vessels. And the stomach has got blood supply intact through right gastric artery and right gastroepiploic artery. And this is the loop actually which provides the blood supply to the fundus part of it. So it has to be, it is very important, because if that is not preserved, then blood supply of that tube will not be preserved. So I hope you understood that. Any ambiguity about the arterial supply of the stomach? Okay, let me tell you another very important thing, that stomach is an organ where vessels are supplying whole part of the stomach, but as they enter inside the wall of the stomach, from submucosa onward, each vessel is an end vessel. So this is why whenever, because of any reason, most likely shock and hemorrhage and burns, whenever the splanchnic blood supply goes into vasoconstriction, stomach feels the brunt of it, because in rest of the intestine the vessels there actually have got a cross anastomosis. But in stomach, although outside it is richly supplied, but inside the wall of it every vessel is an end vessel. So when they go in spasm because of shock, then it immediately affects the mucosa of the stomach, and especially to the cells which produce mucus. And very shortly, very shortly, the mucus production is stopped. And when mucus is stopped, very highly concentrated acid affects on the mucosa and causes ulcers. And this is why they are called, they occur in a state of shock, so they are called stress ulcers. So stomach is very prone to have stress ulcers because of this anatomical fact. All right? Okay, what about venous drainage? Any idea? Where does blood go from the intestine? Portal vein. Yeah, you may ask that why portal vein? I mean, blood from the lung directly goes to the systemic circulation, blood from limbs they go directly, from kidney directly goes to inferior vein. Why on intestine it has to go to liver first and then? One of you.
न्यूट्रिएंट्स होते हैं, उनको लिवर में पहले
पहुंचाना होता है. ठीक ठीक,
उधर से डिटॉक्सिफाई होके.
हाँ, एक तो न्यूट्रिशन को पहुंचाना होता है, दूसरा या वट एवर वी टेक, एक्चुअली वही जो आपका खाना सुबह नाश्ता पका था वो ऑटोक्लेव तो नहीं होके आया था ना. So whatever we take inside has got a chemical burden, it has got a mechanical burden, it has got immunological burden, it has got microbiological burden. Now that, you know, some of them actually, although there is a gut and blood barrier, very strong gut and blood barrier, but at times that barrier becomes weak and those things they just go there. If they directly go into the systemic circulation, person will immediately die. I mean, when there is a liver failure, why patient goes into hepatic coma? Because these toxins, they go directly into the circulation and they act like false neurotransmitters, and this is why person goes into coma. So they have to be managed on their way to the systemic circulation. So this is why it goes through a portal venous system. So obviously blood from the stomach will go to portal venous system. But since there is a watershed at the level of the esophagus, so some of the blood may go to systemic circulation directly. And whenever there is portal hypertension, whenever portal vein is blocked because of any reason, then those channels may open up which are at the lower end of the esophagus, and this is why the upper part of the esophagus, upper part of the stomach and lower part of esophagus may have engorged veins. But otherwise, in a normal circumstances, blood goes to the portal vein. Now, each vessel has got an accompanying vessel, and I'll not go in detail of that, and ultimately they go into the portal vein. There is one vein which is actually runs along the posterior side of the stomach, which is called coronary vein, and that is very upper part, that is very notorious to be very grossly enlarged in case of portal hypertension. So this is about the venous drainage. Anyone can tell me about the nerve supply of the stomach? Yeah, Vogus, Vogus. So there is a Vogus. कहाँ से आती है? हाँ, brain से आती है. कौन सी cranial nerve होती है? All right, okay. So Vogus nerve actually supplies. And what type of fibers it has? Parasympathetic fibers, right? And they are responsible for what? Motility and secretion. Motility and secretion. Apart from that, please remember, there are local nerves as well. Local small nervous connections as well. Yeah, myenteric plexus, very nice, and mesenteric plexus. Myenteric plexus are outside. Yeah. It is in subserosa, and mesenteric plexus are. So, वो कुरान पाक की एक आयत है ना, लक़द ख़लक़नल इंसाना फ़ी अहसनि तक़वीम. Now, each and every cell of the body, each and every organ of the body, if you just minutely just watch it, you are amazed at how it functions. I mean, stomach is just a piece of a bag made up of meat, which has got corrugated inside. But the tremendously complicated and tremendously sophisticated and beautifully reacting systems are in place in the stomach, right? Now, and it's I'm sure that we will never be able to understand it completely, but a brief idea is that actually there is an anterior vagus nerve and a posterior vagus nerve, and they were present anterior and posterior, but when it turned, actually they also swayed like this. The interior vagus, so I'm diagrammatically placing it here. Actually they are present on the interior part of it. So interior vagus nerve comes like this, and it only splies to the stomach. That's it. And end part of it ends in 3 branches, which is called crow's paw, and this is interior vagus. The posterior vagus, however, and it gives a branch to the liver actually, just a branch to the liver, that's it. The posterior vagus, however, is actually for whole of the intestine up to the junction of right 1/3 of the transverse colon with that of 2/3 of the transverse colon. Wahan tak ki all parasympathetic supply is from posterior vagus nerve, right? So this is why when that posterior vagus nerve comes, it gives a branch which is a celiac branch, which goes to the celiac ganglion, and through celiac ganglion then it distributes all over the rest of it. And the portion which is from rectum upward up to that junction is supplied by S1, S2, S3, which are nervi arigentes. As you know, the parasympathetic supply of the descending colon and part of transverse colon is from nervi arigentes. Okay? Acha, now this nerve like that, chup karo beta, don't cross out. Don't cross talk, please. Okay? They supply like this, and here they give a nerve, and this continuation of this nerve, it also gives a crow paw here, but it gives a continuation which is called nerve of Letargit. Forgive me for the spellings. Nerve of Letargit. And then there is one branch of it which actually passes behind the stomach and supply this area. And this was described by a person which is called Gracie. Now nowadays the surgery for vagus nerve is very, very, very rare. I remember when I was a house surgeon and maybe early part of my residency, one of the common operations in our operation list was vagotomy pyloroplasty. Because at that time, imiprazole has not yet been invented. And this is imiprazole actually, we will just shortly learn it. It causes complete cessation of production of acid. And hence, the ulcers are healed. But you know, when that drug was not invented, sometime the resistant ulcers could only be treated by doing vagotomy. And during that period of time, this nerve was considered to be very important, because if you miss that nerve, so you cut all the nerves, but if you miss this branch, then acid production would again start. So this nerve, Gracie was a person who discovered it, and he named it very interestingly as a criminal nerve of Gracie. And this name is still retained in your literature, criminal nerve, because if you miss it, then ulcers may occur, right? So this is the nerve supply of the stomach. And when we do an operation, if we cut both of them, they are called truncal vagotomy, right? And if we cut like this, just the nerves going inside, this is called highly selective vagotomy. There is an in-between selective vagotomy, which is actually an obsolete procedure. So whenever we have to do a vagotomy, actually nowadays, this is the procedure which we adapt. We actually identify the individual twig of it and we cut it. In this way, the rest of the motility of the intestine is not interfered with. And whenever we do vagotomy, not only that acid production is gone, the motility part of it is gone. So it has to be coupled with a drainage procedure. अब मेरी बात समझ में आई? Either you do a gastrojejunostomy, you join the stomach with the jejunum, or you do a pyloroplasty, which means making the pylorus dilated. You just remember these names. When we'll come to the operative surgery, I will let you know. Pyloroplasty. So please remember that whenever we have to cut the vagus, just cutting vagus alone will not solve the problem. Patient's ulcer will be healed, but he or she will have a motility problem. So vagotomy has to be coupled with gastrojejunostomy or pyloroplasty. So that is the nerve supply. And then, very, very important, the lymphatic drainage of the stomach. In your book as well, and I'll also follow the same pattern, we will discuss it when we'll discuss the tumors, because we will be needing that fresh knowledge at that time. So when we will discuss CA stomach, we will discuss that lymphatic drainage at that time. Okay? Is it clear, the anatomy part of it? Any question, any ambiguity, anything you want to ask? No. Okay. I just rub this, and in the meantime, you just आपस में बातें नहीं करनी, खामोशी से ना, in your mind, just think about the physiology of the stomach. What is the function of the stomach? बेटा बातें नहीं करनी, चुप. Think about in the meantime, I will rub it, right? Please close your eyes. You know, I trust you, as I've told you already. यार, when you close your eyes, you start talking. एक मिनट, बात नहीं करनी बेटा, बात नहीं करनी. खामोश प्लीज. खामोश का मतलब पता क्या होता है? Very simple way. Just upper lip is touching with the, and for next 15 seconds, think about the physiology of the stomach. Okay, so after this 15-second meditation, what is the conclusion? Anyone can tell me the function of the stomach? One by one, huh? Oh, very nice. It has to, this is why it is dilated, that it has to store the food. What else? It has to take part in digestion. Not all, mainly digestion is performed by small intestine, predominantly, but definitely it takes part in it. What else? Acid production, which is part of the digestion. Okay. Huh? Source of Yeah, it is source of intrinsic factor as well, which is responsible for, one of you please, absorption of iron, right? Okay, but these are gross functions, but there may be many which actually we don't understand. Now let's briefly discuss the physiology. One of them is obviously receiving the food and doing something so that that food is not only digested partially, but is broken down into small chunks so that the intestine can handle it easily. Huh? A kind of a blending. You're right. Now for that, थोड़ा तवज्जो दीजिएगा तो समझ में आएगा. This upper part of the stomach mainly does not have peristaltic movements, much peristaltic movements. The middle part and the lower part has much of it. The upper part has only a tonicity. It has got a tone, right? The tone sets to low when food is coming there so that it becomes it can receive the food, and later on the tone becomes very high. But rest of it is actually in the middle part and on the lower part and some of the duodenum. Now these movements which occur in the stomach, they are called MMC. Abbreviation of what? Mass movement complexes. Just check it up, I may be wrong, MMC, right? So what happens is that there is a cycle of 90 minutes. Whenever food goes there for 40 minutes, stomach just enjoys it, right? Doesn't do anything. And after that, there is a 40-minute cycle where there is contractions. Now these contractions when take place, they are maximized at the level of the pylorus. And when they reach there, what they find is contracted opening between the stomach and the duodenum. Very small hole. So see, just imagine when food goes like there, goes in the atrium, just tries to go there, they find a very small hole. So a small part of it goes there, rest of it comes back. It comes back. And again passes through that cycle, it goes there, some of it goes there, rest of it comes back. Now this is called antral mill. And this process actually continues. So this actually makes the churning movement of the food and it breaks down into small. आपको समझ में आ रहा है ना? Can you visualize it? Food comes there and just the maximum pressure is there, but when you find a small hole, so some of the chyme, that diluted food is called chyme. It goes there, rest of it just spins back and comes. So with this movement, subhanallah, dekh kitni khoobsurat mechanism hai. Actually this is how food is being. So this cycle goes for 40 minutes. And after 40 minutes, there is a 10 minutes period when duodenum starts contracting so that it can now handle it and pass it into the intestine. So basically, there are 90-minute cycle with which stomach. It's a बहुत ही oversimplify करके मैं आपको बता रहा हूँ. There's a 90-minute cycle of actually this food handling. अच्छा, इसमें एक बड़ी ज़बरदस्त और बात होती है. The muscles of the stomach are arranged in such a way that when solid goes inside, it goes in whole of the stomach. But when liquid goes, the muscles around the lesser curvatures, they contract and they make a small tube-like, a functional tube-like structure. And hence, when liquid comes from the stomach, it need not to mix with whole of it. It actually slips from the lesser curvature and directly goes into the duodenum. In other words, kind of a functional tunnel is being pinched on the lesser curvature, and water goes from there. So these are the movements of stomach, right? Now the other important part, are you tired or not? Yes. You're tired? Yes. You want to sleep? Yes. You want to sleep? Okay, we won't talk much. Let me finish with the histology of it and we'll finish. Rest of it we'll discuss next time, inshallah. Now this also requires attention, please. There are cells which are called parietal cells. Parietal cells. Parietal cells are, the stomach has got crypts. It's basically a columnar epithelium. They have got crypts. The parietal cells are usually in the bottom and the middle part of those crypts. Parietal cells are for production of acid. And acid is produced through a potassium hydrogen ATPase pump. and as a result of it, what happens is that potassium goes inside the cell and hydrogen ions come outside the cell, and just in the last part of it, it actually combines with chloride and forms hydrochloric acid. And this is against a very strong gradient. 10 lakh into 1, 10 lakh into 1, 1 million into 1 का gradient होता है. So it requires lot of energy. So from inside to, in order to push it, it requires energy. This is what is called potassium hydrogen pump. And the understanding actually has emerged recently mean for last decade, that this pump can be blocked by a drug called proton pump inhibitors. Proton mean H. When H has got just plus, it is proton. So proton, this pump is called proton pump. So proton pump inhibitors actually totally blocks it. And the previously used drugs, which are nowadays used as well, H2 receptor antagonist, they affect on histamine, and we will shortly learn that histamine also is responsible for production of acid. So these are parietal cells. Then there are second type of cells which are called chief cells. Chief cells. Chief cells are present on the upper part of the crypts, at the gates of the crypts, and they are responsible for production of two, good morning. Okay, two of those chemical compounds called pepsinogens. Pepsinogen 1, pepsinogen 2, right? Now, previously we knew that there is only one pepsin which is produced by pepsinogen, but recently we have learned that pepsinogen 1 is predominantly produced by stomach, but pepsinogen 2 is also produced in rest of the intestine as well. So this is why in those dedicated centers where stomach diseases are investigated, they also can measure the concentration of pepsinogen 1 separately and pepsinogen 2. If there is a stomach disease, then pepsinogen 1 will be low and pepsinogen 2 will be high, because pepsinogen 1 is predominantly, and this is actually for pepsin. What does pepsin do? When it comes in contact, pepsinogen converts into pepsin and responsible for digestion. Okay. Then there are third type of cells which are called ECL, enterochromaffin like cells, ECL cells, enterochromaffin like cells, and they are responsible for production of anyone? The histamine. They are production of histamine, and this histamine is actually a stimulant of production of acid. In fact, acid is produced, and then there are other cells which produce gastrin, which is a hormone, gastrin. Now, so if you see the production of HCl, it occurs through Vogus, through acetylcholine. Vogus also affects on histamine producing cells. It produces histamine, right? So, and gastrin also produces the HCl. So this is how this whole mechanism. And Vogus, when affects on the production of acid, it also affects on 3 different levels. One is called cephalic phase, another one is a stomach phase, another one is intestinal phase. See, I take you to Al-Maida. In Al-Maida, there will be a chicken broast with a ketchup. How many you have water in your mouth? Now, this is what is called cephalic phase. I mean, when you just think of food or you plan for the food, right, not only salivation, but your stomach also start producing acid in anticipation of the food. This is through Vogus. This is called cephalic phase. And when it goes to the stomach, again there are stimuli which goes and supplies the vagus nerve, and again there is a production that is called gastric phase. And when food goes into the intestine, it has to be stopped. So there is an intestinal phase which acts through other hormones and they stop. वो कहते हैं भाई खाना आ गया है, बस करो. So acid production through, this is just one limb of it. Please remember, Vogus actually acts through this way. The other one is through gastrin, and other one is through histamine as well. Okay. Now, and then in the duodenum, again there are hormones which produce secretin and cholecystokinin. Gastrin is produced in the stomach, and duodenum produces secretin and cholecystokinin. So, like stomach, in the duodenum also, we have got two of these hormones which are produced. One is secretin and what is cholecystokinin. Now, cholecystokinin actually has got two functions. It stimulates the pancreas, because once food comes into the intestine, it requires now pancreatic secretions. So, it stimulates the pancreas to produce that, and it also asks gallbladder to contract so that bile may come and join. And secretin has got an action opposite to that of gastrin. When secretin is produced, there is a negative feedback, and it actually, so when food comes into the duodenum and then acid part of it, the low pH part of it actually comes in contact with the mucosa, it produces secretin, and secretin goes to the stomach through the circulation obviously, or a paracrine manner, and it asks the stomach to stop it. So, this is how the whole mechanism works. So, there is an endocrine control, there is a paracrine control, and then there is a neurocrine control of the stomach. So, this is how stomach function. I think as far as stomach is concerned, we'll stop here. Next time, inshallah, we continue with the rest of